Hey guys, what's going on? This is John from Friends with Your Benefits. Healthcare cost increases are at their highest level in years, and employers are really looking at all areas to reduce the total cost of healthcare without cost shifting. Joining us today to learn about their particular solution, we have Nick Reber, the CEO and founder of Garner Health. Hey Nick, how's it going? Welcome to the show.
Hey, John, I'm doing all right. Thanks for having me.
Of course. So, Nick, before we get into it, I really want to hear about your background. Can you kind of tell us about your background and what led you to found Garner Health?
Sure. So I'm a data technology person originally. I was the head of research analytics, which is really sort of the algorithmic trading development arm of Bridgewater Associates, which is the hedge fund started by Ray Dalio. So I did that for about 10 years. And right around then, I actually started to have some health issues myself. So I got diagnosed with back pain. I had a surgery that turns out I really shouldn't have had. And then I had a complication. I'm now on number 5 here. And that led me to dive into the healthcare world. This is also when the ACA was happening. And I just got fascinated in trying to understand it, seeing it from being a patient, and then learning about the economics as an economics student at that time professionally. Just started to see the tax it was having on most companies, on most people, and most communities. And so I initially then jumped in and I was on the early team and the leadership team at Oscar Health, building that company out, which is a technology-driven payer, individual and small business. And that was a great education for me. I also ultimately came to the realization that if you really want to change some of the fundamental problems in our healthcare system, it's actually really hard to do so while being a carrier. And so we started Garner 5 or 6 years ago out of the notion of, okay, what are the gaps? What are the problems in the healthcare system? And what can you do with them as a sort of independent third-party layer that's really aligned with employers and employees to improving quality and lowering cost?
Very interesting story, Nick. One thing that you mentioned right there is problems with the healthcare system, right? And you talk to a room full of 12 people and you got 12 different answers. But since you're really in the thick of it, really want to hear your perspective, right? What do you see as the top overall problem facing healthcare, and I guess specifically employers in the US?
Yeah, so I think the core problem that we have, a lot of folks are talking about problems with incentives and doctors getting paid more per procedure, et cetera. Um, I think the core problem is one of demand. In other words, that in everywhere else in the US economy and the global economy, there's a tremendous accountability exerted by consumers that producers need to produce really high quality goods at a low cost. Otherwise, they don't get any market share. So I was shopping for a new electric car, and all of the electric car makers are trying to slash their prices proactively. And they're trying to release new high quality features. And why are they doing that? Because they know that consumers are really savvy on what the quality of the service of that car is, and they're really price sensitive. And that means you don't stay in business for very long unless you deliver those things to consumers. And if you then contrast that with healthcare, when have you ever seen a healthcare organization be economically incentivized to proactively lower their prices? And there's really a big murkiness on the quality side. And so my view is that what needs to happen if you really want to change our healthcare system is that you need to somehow find a way to incentivize the demand side. In other words, patients. How do we get patients to make decisions in a much more informed and incentivized manner to improve quality and lower costs? And then and only then will you be able to actually have the right incentives for the suppliers of goods and services, notably doctors and hospitals, to improve quality and lower cost over time.
No, Nick, that's very interesting there. And two things that you said really resonated with me. So the first thing that you certainly said, right, as it relates to healthcare prices, right? So I think one of the fallacies is when the Healthcare Price Transparency Act came out, everyone, or let's say a lot of people, were under the assumption that healthcare prices, at least hospital prices, would drop, and it would be the Amazon effect, right? But it seems like the opposite happened now, where the healthcare systems are actually using those files to increase the cost of healthcare.
Yep.
And the second thing that you mentioned too is it sounds like you're talking about consumerism a little bit, right? So, CDHPs have been around for a very long time, and there's different arguments for and against it. The one that's against it is CDHPs don't necessarily solve for the high cost claims right there. So I just really want to hear from you. What is Garner doing? And I assume this is on the consumeristic side with consumer demand to kind of help employers control the cost of healthcare spend.
Yeah, so it's funny when I started the company, everybody told me you can't change the demand equation, you can't change consumerization of healthcare, right? And to your point, John, like there have been many tries of let's make healthcare shopping like it is on I don't know Priceline or whatever Amazon, right?
Yeah.
And the basic problem is that healthcare is way too complicated, and the insurance mechanism shields most people from any cost. And so the basic idea, think about how crazy it would be to shop for an MRI. Well, I'm in my doctor's office. The doctor said, go walk downstairs to the basement, and go get an MRI. Of course, I'm going to do that. I'm not going to like pull up my phone and shop to drive all the way across town, burn a DVD, bring it back next week. And oh, by the way, I'm through my deductible anyway, so I don't even have any price incentive, even if it was lower cost, right?
Mhm.
And so that's, I think, the reason why the price transparency hasn't worked. It's also the reason why CDHPs haven't worked. It's because the prices is too complicated for people to figure out all of this stuff. Am I going to have a biopsy, my colonoscopy? What's going to be my follow-on care? Oh my God, it's too complicated. And then 90% of the people with any material claims are going to be through their deductible anyway. So who cares, right? So if you want to change the demand in healthcare, I personally believe that you can massively change it, but you have to deal with those two fundamental issues of making it way simpler, and then changing the financial incentives. And that's basically what we do at Garner. And so first thing is that we do a tremendous amount of data engineering and data science work to make it really simple. So all we do is say, hey, go see these doctors within your network. So we do all the data work on all the price transparency, all quality, and synthesize that into one really simple decision called, hey, go see Dr. Jones for your knee pain. And then if you go see Dr. Jones, we are an administrator that basically covers them, works with the employer to give the right financial incentives, cover their out of pocket, if they do the right thing, so that they have a really clear sort of golden path where I get rich benefits if I go get with the program. And if I don't, then I still have my, large carrier network. I just have to pay more out of pocket for it if I ask my neighbor where to go. So I can elaborate on that more, but that's sort of the core difference between sort of, I don't know, consumerism 20 years ago in healthcare versus we think the next wave in the future.
Very interesting. So I guess just right. I mean, some of the consumeristic tools have been out there for a long time. So I assume cash is king, and I believe that is true, especially in the healthcare world. So how do you use the financial incentives to steer from provider A to provider B?
Yeah. So one thing that's important to note is that the carriers are not allowed to for the most part, not allowed to play with their network design all that much. They have to be nice to the hospital systems, candidly. I used to be a carrier. I used to negotiate networks, and I would go to big academic medical centers and say, half of your doctors are doing an amazing job, and half are not doing the best. And they would say, yeah, but the half that you think are low quality end up, driving a lot of our revenue and keeping us in business. So you have to treat them all the same. And so that's why most carrier networks, 96% of the lives on carrier networks, are on these very broad networks with almost every doctor in the country in them. And so employers are then kind of stuck. So, okay, either I have this very narrow network that my employees hate, or I have this broad network and it's kind of a free for all and employees can go wherever they want. And so at Garner, what we do is we are, again, a layer on top of the health plan. So the benefit is that the employer can keep their network, keep their carrier just as it is. And then whether they have a high deductible plan or a low deductible plan, Garner just layers right on top. And we work with the employer to cover the member out of pocket if and only if they first engage with us. That means go on our mobile app or give us a phone call, and then see one of the in-network doctors that we recommend. So we'll take the top third of their network, 30% or so, and say, hey, here are the ones that are really going to keep you healthy. not over prescribe, and also have a good efficient price point for you. And if they go to one of those, then we work with the employer to cover that out of pocket. We often will do that via an HRA mechanism, but we also have ways to do that with HSA compliant plans to create the right incentive. So then a member says, great, I can either use Garner to find a doctor and I'll get a lot of my out of pocket covered for. I'll have incredibly rich benefits. Or I could ask my neighbor, and again, I get my $4,000, $5,000 family deductible, whatever it is.
And that's very interesting in the healthcare world, right? I mean, so many people, make their healthcare purchasing decision based on what their friends and family have done. Hey, who have you seen for your pediatrician, right? My wife's pregnant. We're clearly going with the pediatrician for my older two, but many people that we're friends with have picked the pediatrician just based on our recommendation. It's nothing to do with my field. Just, we know that John's family uses pediatric care, right? It's very, very interesting. So it's something that, financial incentives can be huge. So do you typically recommend that employers, to seeing the high quality provider, they basically make the financial incentives so it's net zero, or do you still recommend some cost share for seeing a high quality provider?
We have a variety of clients that are all the way on that spectrum. I think the folks are sometimes worried about sort of the quote unquote moral hazard of giving folks free healthcare. We already do that in preventative care. It's a law, So, and it turns out that if you get folks to the right doctors, we've seen very, very little or zero sort of induced demand from the consumer side. And we see 27% lower cost per episode if you go to the right doctor, who's going to put you on the right care pathway, lower your costs, et cetera. I can get into that more. So we actually don't mind having a $0 plan. It's actually kind of a cool sales point. Most of our clients though have some cost share. The big thing though is that you have the right amount of carrot and sticks. And so some employers dip their toe in the water with, keeping their plan exactly as it is and adding a little incentive. And we'll get 10, 20% of the care volume switched under those circumstances. We have other employers with a $5,000 individual deductible and a $5,000 incentive, basically free if you do the right thing and incredibly painful if you don't. And we'll get 85 or 90% of the people to go to the recommendation that we want. And so it's really a question of the comfort level for the employer, and you can just dial it up. That latter plan will get a 20% cost trend reduction. The former one might get you 3%. And so it's really the amount of the comfort level with the employer and what their benefit setup is, and we dial it up or down accordingly.
Now, what do you base the definition, in Garner's mind, of what a quality provider is? Like, let's say, for me, right, my health insurance carrier is Aetna. Is it based on what falls on Aetna's list, or is it, Garner's list?
Yeah, so it's definitely, we do this all in-house. We've aggregated, as far as we can tell, the largest claims database in the country. It's 320 million patients. It helps to be a third party, not one of the carriers, because the carriers can't get each other's competitive data. But we can as a neutral third party, and we've got a lot of partnerships on that. We've got 5 times more data than any of the large carriers for perspective. And then a lot of the way the carriers have done it, as a data scientist, and of course I'm a little biased here, but a lot of those methodologies were invented in the 90s or late 80s. Like, they're just really old stuff using legacy episode groupers. And there's a reason why all the doctors and clinicians hate those old approaches, because they're not very clinically valid. So we have a really new approach. We have a lot of the larger hospitals and provider groups using our data now. And so so I think that's really important. And under the hood, there's really 3 things that we look for. And I can go how we do this more statistically, but really it's around which doctors produce great health outcomes. That could be primary care doctors managing chronic conditions. It could be a surgeon having great outcome after surgery. So outcomes all across the board. The right care pathways. So which doctors run the right diagnostics at the right time, give the right surgeries at the right time, do the right cancer screenings at the right time, all the right stuff for the right patient, given what the medical literature says. And then the third part is sort of more just purely financial, which is low cost surgery. As long as you keep the quality high, can we lower the price of a surgery, the site of service, et cetera? So the average surgery in the average market in this country has a 5x difference in price with no discernible difference in quality. So here I am in New York, and the lowest decile colonoscopy is $500. The highest decile is $12,000. and there's no quality difference between the two. We might as well get the lower cost if we can.
So Nick, given your economic background, is it fair to say that within healthcare, there's really no correlation between price and quality for the most part?
Yeah, exactly. So we actually have a piece on this. We've tried hard to find any correlation in almost anywhere, and what we see is the price per procedure and the outcomes after that procedure, or the longitudinal patient outcomes. There's zero correlation. Mostly, what drives price is market share in a market. So if the hospitals have a lot of market share, they get to drive their price up. There's actually some literature on that. That does not mean they have better quality. In fact, often the opposite. They go buying hospitals indeterminate of quality. The interesting thing is, if you look at the total cost of care, not just the cost per procedure, but the total cost of care, we actually see that higher quality equals lower cost, for the obvious reason that healthier people have lower total costs. So if you have better quality, putting people on the right drugs, putting them in the right care pathways, or having low complication rates, that doesn't change your price per procedure, but it means you have fewer procedures, so your total cost is lower. So the nice thing about our model is that you can have high quality and low total cost of care. And those are the doctors that we're looking for, those in that sort of quadrant right there.
Fair enough, Nick. So let's say there's an employer out there, right? And they're thinking about Garner. And a lot of times as a consultant, I get, asked a question like, hey, John, how much can this potentially save me? And, just for perspective, many of the carriers have their narrow network solutions. And if you're able to put one in a particular area, these savings could be anywhere between 10 and 20% on a full replacement basis. So let's say a client out there is really considering Garner and they go with all your best in class recommendations. What do you think the medical savings as a percentage of total healthcare costs could be?
Yeah, so our average across many dozens of clients and tens of thousands of lives has been a 12% reduction in the total cost of care trend. It's important to note that the benefits of our model is you don't have to narrow the network, you don't have to change your network at all or your carrier. And we have some clients when that are over 20%, 22, 25% savings. So and we actually at Garner take total trend risk and downside risk with our clients. So we put 100% of our fees and even then some to guarantee those trend reductions. So it really depends. We're sort of this dial that an employer can say, okay, I'm going to keep my network and carrier. I don't want to mess with all of that. I don't want my employees to lose access, but I'm going to turn up the dial and I can do very light or I can do very aggressive. And so you can get at least as much savings as those narrow network plans. But in our view, again, I'm biased here, but you can do so in a much more sort of progressive and less disruptive manner. And that's the basic idea of our model.
Fair enough. The other question I commonly get is member engagement, right? So you talk about the app. What percentage of members typically use Garner, right? Let's say there's a group out there that has 1,000 employees, call it 2,200 members. So, just based on that, what percentage would you typically say would use, Garner based on your book of business?
Yeah, you're going to challenge my mental math on the here, but on average, we get 45% of the folks to use the tool to find a doctor every year, and that's of all the members on the plan, including, again, there's about a third that will never have any care in that given year, and so it's really the majority of the people who need to find a doctor will end up using our tool. The vast majority. It's worth noting that there's a lot. You probably know this well. Folks define engagement in a lot of different ways. The important thing is because we're a financial administrator, we're going to match a search record with the actual claim from a member. And so it's not just whether they logged on or whatever or signed up for the app, but part of our funnel that we report to clients is not just whether they searched, but actually did they have an actual claim. So, yep, we recommended they see Dr. Jones here, and there they had a claim with Dr. Jones. So when we say that we have most of the folks using our tool, that's actually backed up not just by search data, but actually by claims data as well. And again, that depends a little bit how many carrots and sticks you set up. Again, we have clients with 85 to 90%, and we have clients with 10 to 20%, but our book of business average is about 45%, about half of people using our tool every single year.
Very, very significant right there. I mean, some of the point solutions out there, you might be targeting 1-2% of the population. Some are, closer to 10, but 45% is very compelling. So how do you actually explain Garner to employees, right? Let's talk about communications for a second. Like, how does an employer go about saying, hey, here's Garner?
Yeah, I mean, the basic thing is I think we roll out the best when we say, hey, Garner is going to be the sort of core way that we suggest that you find top performing providers. So whenever you need care, we have a series of tools here at Garner, whether that's on the phone, the mobile app, or the website, to help find the top performing doctors. And top performing doctors are ones that are shown with actual patient records to produce really great health outcomes for you and your loved ones, follow the evidence-based literature, and keep you healthy really over time. And because your employer cares about keeping you healthy, they're willing to also pay for your out-of-pocket when you do that. So you're going to get richer benefits with very low, or for certain employers, zero out-of-pocket, and you're going to get much higher quality care based on the actual patient records. And all you have to do is again, use our tools, but you have to do that before you see the doctor. You can't end up, oh, my neighbor said this, and then I'm there, and then I want my money. So that's sort of some of the education we do. We try to keep that really simple, and we found actually people understand, oh, I have X thousands of dollars of incentive if I do this thing. Got it. What do I have to do? And we go from there.
Talk to me about employers who have point solutions in place with $0 copays, right? So I think of like a Hinge Health or a Carum.
Yep.
Can Garner Health leverage those existing point solutions with financial incentives?
Totally. So I would say, we have a lot of employers that have all of those, and we often act as a bit of a central hub to those. So in our user experience, we can link out to your mental health, your musculoskeletal, your cardiometabolic, whatever you have in place, your center of excellence. And we will often sort of double the utilization of those programs because we'll actively drive folks to there. Now, if you have a $0 copay, obviously you don't need a further incentive. You've already incentivized that in your plan, but that's no problem. It just means you don't get any extra financial incentive. But we have a really, I think, a real benefit from a user simplification is, hey, everybody, whenever you need care, go to Garner, and then we're going to make sure we're sending you to the right place, whether that's a digital therapeutic or bricks and mortar in your carrier network, whatever it is. And so that's typically how we've done that.
One thing I wanted to circle back on is earlier you mentioned that your solution is HSA compliant, right? So let's go back to that $5,000 deductible, and let's say it's a high deductible health plan, qualified HSA plan. How does Garner actually work, with the HRA, or is it a different model in that situation?
Yeah. So again, as I sort of alluded to, our base model is to administer our funds via an HRA. However, that is very flexible. Now, we can administer our HRA in a post $1,600 deductible manner, which is totally compliant. We get great engagement. It works great. That's all. And so that's all good and easy. Another way to do it is to actually is to administer the incentive as an HSA deposit. So a lot of employers are getting a little tired of the huge expense of funding a $500 or $750 HSA seed. And they're like, all right, this is all that money I thought was going to save me money, when I thought consumerism was going to work. It's really not. It's kind of just out the window. Now I want to take some of that money and say, hey, employees, if you want that money, you're going to need to, kind of earn it by exhibiting good behaviors, most notably, seeing the Garner recommendation. So if you do that, then you're going to get an even bigger HSA seed this year. Maybe it's $1,500 this year to cover your out-of-pocket. But if you don't, you're going to have a much smaller seed. So that can really work, I think, quite well. We can integrate over time, and we'll actually be adding our own HSA solution before too long here. So that's sort of how we do that.
So Nick, what's your target market, right? I assume it's primarily self-insured employers, but you're talking 2,000 lives, 4,000 lives. What's the target market for Garner?
Yeah, we actually work full. We have a great fully insured business and self-funded business. You might think, well, why would I do this if I'm fully insured? It turns out there have been a lot of sort of HRA buy down programs out in that fully insured market. I'm a 100 life group. I have a 25% renewal. What do I do? Well, I can buy down the benefits, and usually it's sort of do a little bit of self-funding on top. Here, instead of that, you can add a Garner incentive account that covers the member out of pocket. And, you can buy down your benefits, save 15, 20%, take half of that to fund Garner. And then A, you not only get savings year one, but B, your renewal ends up being better in future years because you're controlling your claim. So we have a great book of business. We sell all the way down to 50 lives enrolled on the plan. And so I think our book is really everything less than, I'd say we have some of the larger Fortune 10 companies, but a lot of what we've done is either folks who really love the quality. If you're a very large employer and you really love the quality and that's your notion, great. Otherwise, 10,000, less than 10,000, and folks who are struggling with a tough renewal, 9, 12, 20%, whatever it is, and looking for one solution that they don't want to change their networking carrier. So it's like, all right, I'm up 12% this year. How am I going to handle it? Well, Garner's, I think, a really good solution there for that people that are looking for almost a one-stop shop to help control their medical trend. And again, 50 to several thousand, that's kind of our bread and butter.
Okay, fair enough. Where do you see Garner going in the future?
Well, so our core focus is and as it will be the employer space, and continuing to invest in that, build out more features around making the payment system easier and easier, making our search experience better and better, adding things like everything from the ability to book online and telemedicine to better payment features. But I think the other thing that we're really excited about is I'm starting to really work with the provider ecosystem. And some of those are some of your larger primary care groups who need to make referrals to high quality specialists, whether that's your on-site clinic, your telemedicine vendor, or some of the larger bricks and mortar groups. And then what's fascinating is we've also had a bunch of hospital systems call us and say, hey, we hear you're controlling a good amount of the volume, the demand in our market. Will you help us, understand our quality and see if we can basically earn back that volume from you? Or is there a way that we could give employers that have Garner, essentially, can we lower our costs in any way, shape, or form to those employers that have Garner? And so, we're excited about working with those parts of the provider community that really do want to improve, that are understanding their economic incentives are different, because there's folks like us driving volume only if they do the right thing. And so a big part of our business is sort of lifting all boats along the way, helping those providers that want to improve their practice doing so and to lower their costs.
Fascinating. Yeah, I haven't heard of many solutions out there, trying to work with both employers and the healthcare providers. So definitely kudos to you guys. Let's say there's an employer out there and they want to learn a little bit more about Garner. Where can they go?
Yeah, you can contact us. Obviously, you can go to getgarner.com. You can also email us at sales@getgarner.com, or my email address is nickr@getgarner.com. So feel free to reach out. Always love to get questions from you all.
Great. Well, Nick, thank you so much for coming on the show today. Really appreciate your perspective and educating us on Garner.
I appreciate it. Thanks, Sean.
Absolutely. And for our audience out there, we want to hear from you. What are some of the challenges that you see in the healthcare system, and what can employers do to really help solve it? Comment below.